And I would add to that in 803 too. I think it's very difficult to know how each of these drugs compare with respect to efficacy. You mentioned pembrolizumab and TAR-200, nadofaragene, some others on the horizon, cretostimogene, detalimogene, um, and of course gemdosi. So I think all of these drugs appear to be uh, uh, beneficial for a subset, but in whom these drugs work and when is still a major question. And more importantly, the comparative effectiveness across the whole spectrum is still, I think, largely unknown. We can compare complete response rates at any time point um, across each of these drugs, but I think the more interesting um, endpoint is durability of response. And I think that's what patients are more interested in as well. So a lot of these trials don't have long-term data, and so comparing across them isn't even possible to begin with. And without head-to-head studies, it becomes very difficult because even though they all more or less conform to the same definition agreed upon by the FDA, um, for BCG-unresponsive disease, there's still a fair amount of heterogeneity in small phase 2 and phase 3 single-arm studies. So I'm hesitant to answer that question. In terms of how they compare with respect to patient adherence, I'm not sure my experience with any of these is large enough to be able to comment on that. Um, I, in general, find that most patients are able to tolerate intravesical therapy. Pembrolizumab is a little bit different because it's an immunotherapy and it's given intravenously. And there are systemic autoimmune mediated adverse events that we don't see with intravesical therapy. So I will say in my own practice, I've relegated pembrolizumab either to combination therapy, usually in the setting of a clinical trial, or as kind of a last line of defense against somebody who really doesn't want cystectomy, has totally run out of options, or doesn't want intravesical therapy. But again, that's a conversation that we have about whether or not the systemic adverse events are worth the 19% complete response rate in BCG unresponsive CIS at a year. So when I have a patient sitting in front of me, I usually talk to them about all of the options. I just remind the audience that cystectomy is still very much an important part of this decision-making process. There's patients who have very high risk non-muscle invasive bladder cancers that are better served by removal of the bladder. And I'll just say briefly, I think those are generally T1 patients, especially if there's concomitant CIS or variant histology, lymphovascular invasion, or if there's extravesical disease like in the urethra or let's say distal ureter or something like that might drive me towards saying we have a problem here that's not going to be addressed by conservative management. And so that's the first point I think to be made. With respect to all the other options, you mentioned all the options in the previous question. How do we go about selecting which of those? Well, I'll start by saying I have a lot of clinical trials open, and I'm discussing those trials actively with patients. And I do think there's still a role for these clinical trials, despite the approval of several agents in this space now. And that's because none of the agents that are approved are perfect. There's still a number, the plurality of patients are not responding to them. A and B, there are some side effects, and C, there are some ability to source some of the drugs that you need to use in combination, such as BCG for N803. So I'm not saying that we don't ever use those drugs; we use them frequently. But I'm also still talking to patients about clinical trials. And then how patients select, more or less for themselves, which they're going to choose. Let's say they're not interested in cystectomy, they're not a candidate for a clinical trial, or they're not interested in it. And then they essentially have gemdosi to choose from, valrubicin, although we rarely ever use that, N803 and nadofaragene. the patient, I think, more or less makes that decision about which drug they're going to choose. So right now, I'm not actually funneling anybody to anything, just having a very broad discussion about all of the options. No, not as they relate to the clinical trial. I've found well, let me just clarify that I have not actually been able to prescribe N803 just yet. I think, on the horizon very soon I'll be able to offer this. But I have not found nadofaragene or pembrolizumab or gemdosi to vary much from what has been described in the literature. So it's a really difficult question to answer for some of the reasons we've already mentioned in this interview. But um, I'll start by saying that if somebody has really high volume CIS, poor urinary function at baseline, or T1 disease with variant histology LVI, concomitant CIS, or extravesical disease like in the prosthetic urethra or upper tracts, that's somebody I'm tending to push more towards cystectomy, and that's largely a clinical decision. I'm just using clinical factors, especially if they're young and healthy and they're a good candidate for orthotopic diversion. And so I think that's kind of the first point to be made with patients is whether they're a good candidate for cystectomy or not, and whether that's the right thing. And but in the case where somebody has just a small amount of CIS that's failed, let's say precisely 7 doses of BCG in a 5+2 fashion, and I'm not convinced that we need to remove their bladder just yet, because the volume of disease is small and the amount of stuff that we've tried for them is not great, then I am inclined to say, okay, let's consider your clinical trial options or your standard of care drugs like pembro, nadofaragene, and 803. So I kind of make that decision very early on. Now, whether they choose the clinical trial option or standard of care option is entirely up to them, and the logistics of clinical trials and all of those things. Patients need to be good candidates for clinical trials and be eligible for them, and be willing to sign up for them, and in some cases be willing to undergo randomization. So there's a lot of questions. I would still say in my practice there's still a large number of people who are eligible in that, and that's because we have really good clinical trials open, and I can just frankly get patients free drug. And I think, if you look at the NCCN guidelines on the second page, it says, when there's a clinical trial option, this is generally something that patients should strongly consider. So I'm still using clinical trials in my practice. I don't see that changing anytime soon either. For patients who are not eligible for those trials, I then I'll talk to them about their standard of care options. We do have the ability to offer gemcitabine in combination with docetaxel in my practice. I'm forthright about the data and the low quality nature of those data. Also forthright in some patients are, for whatever reason, really not able to tolerate. I'm suspecting it's actually the gemcitabine as compared to the docetaxel, but and so some patients choose not to do gemdosi. Some patients will do nadofaragene, especially those that travel in and they want to just do their cystoscopy in the morning and then do their treatment in the afternoon and then leave the same day or the next day. But there's also people, especially I think kind of the medically literate folks who really do a lot of research and they say, hey, wait a second, 803 has a 36% um, um, recurrence-free survival rate at a year, or I guess I should say, CR rate in the CIS, BCG-unresponsive CIS at a year. Isn't that the sort of the best option? And my conversation with them is the same conversation I had with you. It's very difficult to compare across the trials. It is higher than the FDA population for nadofaragene. Whether it's better or not, I think is still very much a question. But those patients, many of them elect to do or are electing to do in 803. I have kind of a wait list of people who are waiting for that. So I think There's a lot of different ways to choose, and in general, what I would say is I let the patients choose, and just give them the data and let them decide for what's right for them.